This program is brought to you by Stanford University. Please visit us at stanford.edu.
Tim, next speaker, again, is a very well-known figure in aneurysm research. Tim has been working for years to try to develop an effective, really the first broad-based clinical trial to suggest that there is an effective treatment for early aneurysm disease. And he's actually made consistent, slow but steady progress in that area. And we've asked him today to talk about, well, not through any fault of his own, I'll tell you that, novel therapies for abdominal aortic aneurysm disease. And thank you for joining us today, Tim.
Thanks very much, Ron.
Sorry, my computer is...
First of all, congratulations on pulling this together. It's really been a nice conference, and this morning I thought was great. The engineering talks were, I thought they would be a little heavy, but they were really, everybody did a really nice job. A friend of mine who's a mechanical engineer has told me that the way you can tell an introverted engineer from an extroverted engineer, and some of you might know this, but the introverted engineer, when you talk to them, they look at their shoes. The extroverted engineer, when you talk to them, they look at your shoes. But I think that the bioengineers may be cut from a different mold because the talks really were quite engaging today. So what I'm going to talk about, really three things that I want you to know about when I'm done, hopefully. One is to talk about the current medical treatments that are available that we might treat aortic aneurysms with that might affect the growth rate. So I'm not going to talk about exercise for obvious reasons, and I'm also not going to talk about Jun kinase inhibitors because we don't have any that are out there right now. But I'm going to talk about the other drugs that might work that are out there and available. I'm also going to talk about, just show you some unpublished data that we have regarding MMP2, MMP9 that sort of makes us maybe rethink what we thought we knew about those things and how aneurysms are developed. And finally make a plea for some sort of developing a consensus about collecting samples between institutions so that as we go down the road, we might be able to utilize samples across institutions to get more information and perhaps even have some NIH support to develop that because it would really be a powerful tool for us. So in terms of targeting growth, rupture is a rare event, so we couldn't use that as a marker for how we're going to measure medical treatment. Predicting wall stress is preliminary. There's not enough information right now, although we heard a lot of good, saw a lot of data today that suggests it may be a good marker in the future. It's not currently a good marker. So the best predictor that we have of rupture right now is the maximal aortic diameter. Growth has been prospectively studied in these aneurysms, and we know what the growth rates are, although they're inconsistent and they can change from time to time. Serum markers, as we heard this morning, aren't yet useful, but we'd really like to have some surrogate markers that might be more sensitive than growth to predict which aneurysms are going to grow. But again, we're back to growth rate as our best parameter. Now, one of the things that we'd like to really be able to do is we'd like to be able to stop the growth of an aneurysm. That would be ideal. And when we think about the biology of the aortic wall, all of the things that we've done in the past have been mechanical. They've been ways that we've tried to mechanically control the growth of aortic aneurysms. And one of the pieces of information that has come from that, which has been really interesting to me, is that if you took a 5.5 centimeter aneurysm and you took the wall stress off by putting a graft inside the aneurysm, is that the aortic wall could actually remodel inward and could shrink around the aneurysm sac. And it's surprising when you look at the aneurysm wall in that tissue that there's not very many smooth muscle cells left. There's a lot of inflammatory cells, but somehow that wall is able to do that. So it tells us that there's still a capacity for some sort of remodeling if we could make some adjustments that would allow that to happen. Now, obviously, stopping the growth or getting an aneurysm to shrink would be probably overly optimistic for a clinical trial. But what this graph shows you is that one of the things we could look at is if we could slow the growth of aneurysms, since they occur in the latter stages of life, and most of these patients have other comorbid diseases, it would really impact the number of patients that we have to treat, for example. And so this shows that our aneurysm growth is exponential. And if we took a 3.5 centimeter aneurysm diameter here, and we followed that aneurysm over time at the normal expected growth rate, we would see that about 4.5 to 5 years, that aneurysm on average would require repair if we used a threshold of 5.5 centimeters. However, if we could slow the growth rate down by these numbers here, for example, 40%, that would push that number out to about 8 years. And so at that point, many of these patients would have died of other causes, and they may never have to have their aneurysm repaired. So even if we weren't completely effective in stopping the growth of an aneurysm, by slowing it down, we could have a big impact on the disease. Now, the factors that might impact aneurysms include hemodynamic factors like beta blockers, ACE inhibitors, angiotensin receptor blockers, in that general category. Anti-inflammatory drugs such as statins, aspirin would fit into that category, but we wouldn't be able to do that randomized trial. Tobacco use and protease inhibitors. And among the protease inhibitors would be the tetracyclines. The macrolide, the mechanism for macrolide antibiotics isn't all that clear, but I put it in that category. This is a really nice review, and for those of you who haven't looked at this yet, I think it's the best review. It's published in PLOS 1, and this is the first author, and it was just published several months ago. And what it is it's a meta-analysis of all the studies that have been done. It was done by authors that you've never heard of because none of them are vascular surgeons, and so they really came at this from a different view. And I think it adds a lot of insight to the what we're looking at. But what I wanted to show you here is highlighted is that when we started to think about beta blockers as an inhibitor, all of the data we had was from cohort studies. And so these early studies from Leach and Godowski were what we're looking at. And we said, well, how much effect are they seeing in these cohort studies? And so what they saw in these studies was inhibition. So the growth rate was inhibited by 2.7 millimeters per year, 1.4 millimeters per year in these studies. And so these are the data that led to the prospective clinical trials that looked at propranolol. And what we found from those prospective trials, even though this looked quite promising, is that propranolol was not effective. And so what I want to also for you to notice is if you look at these data, the cohort data that we had on beta blockers, and you look down here at the cohort data that we have now on statins here in these two trials, we're seeing some similar inhibitory effects from the statins. Now the beta blocker trials, as you know, did the two trials, and both of them showed that that beta blockers weren't effective. Part of the reason is that propranolol is a really horrible drug. Most patients can't take it very long. Most of them didn't in the trial. So part of the reason the trial didn't work is they couldn't take the drug. I think if you ask the question, do we know if a non-selective beta blocker would work in these patients, we don't know the answer to that. So other beta blockers might be effective, but propranolol wasn't in these trials. And we also know that it was poorly tolerated. Now what about statins? And so there are a number of studies that have looked at statins and how they might affect aneurysm growth. And so the ways they might affect that is they might lower cholesterol, and there's maybe some association with cholesterol and aneurysms, although that's not a very clear association. There's no relationship between aneurysm growth and cholesterol levels. That's been established in this study. Statins do reduce MMP9 levels, and we talked before about MMP9 maybe as a marker for aneurysms. And statins reduce expansion rate. And there's been a couple of studies that have showed that. But again, these are cohort studies, and actually there was one that I added here that was just published in the last several months. Now this study, the one that shows the largest difference in the growth rate, if you read through this paper, what they say is this is really the poorest study in terms of its design and probably the data and the believability of that data. But if you look at the other numbers, minus 1.2, 1.3, 1.6, you'd say, well, those numbers are fairly consistent, but they're also fairly consistent with what we saw with the beta blockers in the cohort trials. Now, one of the problems with the cohort trials is that the negative data might not be reported. There's obviously biases in the way patients are treated. For example, if we know that diabetes affects the way aneurysms grow, and that in some of these trials you would expect that maybe more diabetics would be on statins than non-diabetics. And so if that were true, it would certainly have an impact on the trial. There may be some relationship between smoking, and although some people have tried to look at these other factors, there's just a lot of things that come into play when you look at cohort studies that may affect or give you biases in terms of your observation. And one of the most important things, again, the negative data, is if you did that study and you looked at it and it was negative, it would never have been published. So could we randomize patients with abdominal aortic aneurysms to statins? And I think the answer is no. Now, why should we treat patients with statins? There's a couple of papers that suggest that it should be done. The American Heart Association, the ATP3 guidelines now consider aortic aneurysm a peripheral vascular equivalent. Their recommendation is that you treat these patients with statins. Now, some of the data for that would be from Dr. Hertzer's old data showing that patients with aortic aneurysms have a high incidence of coronary disease. There was a paper published in 2006 that showed that AAA patients on statins live longer, suggesting that it may be another reason to treat those patients. When we first started looking at this, about 30% of aneurysm patients were on statins. We recently did a survey of 15 centers that are involved in our clinical trial, and that number's up to 66%. It'll probably go a little bit higher, although it won't go much over 70% because a lot of patients won't tolerate statins. But right now, based on the ATP3 guidelines and the fact that most of these patients, or many of the patients, are already on statins, we can't do a randomized trial of statins. I don't think it could be done. Frank's looked at this, and we've looked at ways that we could do it by 2-by-2 randomization, but I think it would be an unethical study based on the fact that many of these patients have other indications to be on statins, so I don't think that's ever going to be done. What about tobacco use? Tobacco use has been shown to be associated with an increased growth rate of aortic aneurysms, and there's been a couple of good studies that have looked at this. It's clearly one of the biggest risk factors for development of aneurysms. Some people have suggested a dose dependence, but I don't really think that's true because I see too many patients who smoked for 10 years and then quit who show up with abdominal aortic aneurysms. But the impact of continued smoking is small, but it's real. And so it's probably about 15% in the best quantitation that's been done so far. There's some effect, so if you're continuing to smoke, your aneurysm is going to grow a little faster, but it's not going to be a huge difference. The relationship between ACE inhibitors and growth rate is really unclear. The relationship between aneurysms rupture and ACE inhibitors is also, I think, unclear, although there is one paper that suggests that aneurysm rupture is associated, or discontinuing ACE inhibitors was associated with aneurysm rupture. There was a nice note or letter that Frank Laterly wrote about that sort of poked some holes in that article. So I think after you read the article and then read through this, you had really some concerns about the validity of their answer or their conclusion that ACE inhibitors were that important in development of rupture. Macrolides have been tried in aortic aneurysms. They've been tried in coronary artery disease. The idea with macrolides is that chlamydia was a factor in aneurysms and in progression of coronary artery disease. And so if you block the chlamydia, you could stop the progression of disease. And one of the things that they found in these studies was that the chlamydia titers had no relationship to the growth of the aneurysm or the drug treatment, and so that really wasn't how it worked. However, they did see in a really small randomized trial some growth inhibition of one of the macrolides, erythromycin, and so it's a viable treatment option that potentially could be a way to slow aneurysm growth, although there's very little data for that. Tetracyclines are non-specific MMP inhibitors, and we really started to look at this in about 1996. Rob Thompson's study was the first to show that in a model that if you gave tetracycline, you could inhibit the growth of aneurysms. So he really got the ball rolling with this. And we've seen that you could reduce MMP levels in human tissue, which was an interesting observation, by treating them with doxycycline before surgery. We did a multi-center small trial treating patients with doxycycline just to look at the safety of the drug, and we found that we could reduce the MMP9 levels, circulating MMP9 levels with doxycycline. There's really only been one trial that's looked at it clinically. This trial is not a great trial. The number of patients is extremely small. The patients were treated for 3 months, and then they were followed for 18 months. And I don't know how they came up with these numbers, but for the first 6 to 12 months, if you look, based on their ultrasound measurements, the patients were treated with doxycycline for that 3-month course, showed no growth, and then as you get out to 18 months, the difference was lost. And so you could argue that maybe the doxycycline effect was lost at that 18-month time point, and you had it here at this time point. So the data is suggestive, but it's fairly weak. This is a summary of a paper that we wrote for Circulation, and we went back and looked through all the data, and I think this paper is actually pretty good in terms of looking at all the studies that have been done and grading the evidence for these trials. I think this new paper that was in PLOS 1 is also probably a little bit better, but basically what we see is that there's level A evidence, which is randomized controlled trial showing that propranolol doesn't work. All of the other things we're talking about were either level B or level C evidence, so they're cohort studies which really are inconclusive at this time and need further trial. Ron mentioned the doxycycline trial, and this is something that, again, it started really with Rob Thompson's work, and Rob and I have worked on this for a long time. In fact, I had hair when we started working on this, but basically what the trial is quite simple, and it's to look at patients with placebo and doxycycline to see if we can figure out if it's going to be inhibitory. The current status of that trial is we have an R34 from the National Institute of Health to Michael Tarrin, and the R34 is a planning grant. So in that phase you get $100,000, and that $100,000 is basically to put all your protocols together so you can submit your R01 for the trial. And so right now we have 15 centers that are in the trial. We have data from all of those centers looking at the number of patients that they see, the number of patients that would be eligible for the trial. The data coordinating center for this would be at the University of Maryland with Michael Tarrin. Rob Thompson's group would run a biomarker center, so this would be a place where we would send samples and look at blood markers and try to correlate, and as we follow the aneurysms with CT scan, try to figure out which of those markers may be useful for indicating growth of aneurysms. We're going to have an image analysis center to look at all the CT scans, and a clinical coordinating center at the University of Nebraska. So mechanism of action, we talked about how statins might work, because one of the things they do is they seem to be anti-inflammatory, and so they lower cholesterol, but they have this so-called pleiotropic effect, which means we don't really know what they do, but they do a whole bunch of things that decrease inflammation. And so tetracycline also lowers MMP9 levels, and we know it's a non-specific inhibitor of MMPs. And so the question is, what's the role of MMP9 in abdominal aortic aneurysms? And I think 4 years ago we thought we knew this. What we thought we had figured out was that Rob Thompson first published this, and then we published a second paper. And this paper is what we looked at is if you had a macrophage MMP9 and that stimulates smooth muscle cell MMP2. Now, if you take out either of those, so you have a knockout mouse and you take out that at either one of those, what happens is you lose, the aneurysm's gone. It's completely gone, and the tissue looks normal. But what that told us is that those two MMPs weren't working side by side. One was doing a little bit, the other was doing a little bit, because if that were true and we took one out, we wouldn't lose the effect completely. What it told us is that they're working in a linear fashion, so that if you take one out here, take one out there, then you completely lose the effect. So what we thought is that those two enzymes were degrading the matrix, and somehow they were doing it. One was starting the degradation, the other one was finishing it, and so they were responsible for aneurysm formation by degrading this. And this is some unpublished data that we've just generated in the lab as part of a paper that we've submitted. But it really makes you think about how little we might know about this whole process. So in these experiments, what we did is we took macrophages from knockout mice. And so these are macrophages from MT1 MMP knockout mouse, MMP2 MMP9. And these are wild-type macrophages. And then what we did is a fairly standard elastin degradation. So this radio-labeled elastin degradation. And so this is the wild-type macrophage. This is how much elastin it degrades in 5 days. Again, a fairly standard assay. And the thing that we found out that surprised us completely was that the MMP9 knockout macrophage doesn't degrade elastin. It degrades very little elastin, in fact. And the MMP2 knockout macrophage doesn't do much better. It does a little bit better. And this knockout, which we don't, is a collagenase, is quite important in elastin degradation. And so what this means is that we don't yet understand. We know that if you take these out, you affect the development of aortic aneurysm, so they're important in the process. And we used to think they were important because they degraded elastin or collagen, but they don't do that. So what they're doing is something that's completely different. And so Bill Parks has written a really good paper, and Bill Parks is one of those guys who works on MMPs, and he sees a little bit bigger picture than all the rest of us see. But what he has written in his paper is that, first of all, that most MMPs are not expressed in normal tissue, but they only come about because of inflammation. Secondly, that we have focused on the matrix as a target for the MMPs because that's how they were identified, by their matrix, their ability to degrade certain types of matrix. But what he points out is that actually their targets for degradation are probably not primarily matrix. They actually work in the inflammatory cascade in entirely different ways that we don't yet understand, and that their ability to degrade matrix is only one component of what they do. And I think what this shows us is their ability to degrade matrix is a small component of their role in the development of abdominal aortic aneurysms. Now, the last thing I'm going to talk about, just to mention, is some SNP analysis that we worked on in our lab. And I think it's clear that all of the studies that have been published on different SNPs that might be related to aneurysms, except for the one from Paul that you heard about today, have looked at a single SNP and then looked at that and said, is this associated with abdominal aortic aneurysm? And it's clear that we're not going to find that. We're not going to find the one that's causing abdominal aortic aneurysms because people like Helena Kavimi have worked on that for years and years, and it's probably not there. It's multifactorial, and we have to look at all these different factors, and we're going to have to come up with a way to analyze this data that doesn't look at one of them. We're going to have to look at all of them. And so we've looked at 12 genes of interest, and so this data would be complementary to what's been done here at Stanford, where they're looking at gene expression. One of the ones that looks really interesting, if you just looked at one, would be this IL-6, for example. But you'll also see that this GG variant of IL-6 is in patients who don't have aneurysms. It's in patients who have aneurysms. So that's not going to distinguish between an aneurysm patient and a patient who doesn't have an aneurysm. And so what we're going to have to do is we're going to have to look at these, because some of them also are quite interesting, but we're going to have to look at these and we're going to have to see how they factor in and how they might push the patient in the direction of having an aneurysm, but not individually causing the aneurysm. And another way I like to think about that is if you think about Marfan syndrome, patients in that family who are affected all have that same genetic mutation. And yet if you look at those patients with Marfan syndrome, some of them may have no disease and some of them are severely affected. But they have the same mutation, so how could that be? Well, what it tells us is that one mutation is only one part of the problem. They have a whole array of other polymorphisms that are affecting the expression of that gene. And we have to look at those other polymorphisms, and we have to mathematically look at them and say, how can we look at all of these things in the way that the Stanford group is looking at RNA expression and come up with mathematical formulas that give us a better idea of which ones are contributing to the disease process. So what I would like to say about that is I hope one thing that might come about from this meeting would be that there might be another meeting or a subgroup of people who are interested in this who would get together, and that we might develop some protocols so that when we collect blood samples at the University of Nebraska, or they collect blood samples in Australia, or they collect blood samples here at Stanford, is that there's a protocol for how it's done and how it's stored and how it's aliquoted. And if that were done properly, then I think it would help us to be able to transfer these samples and work with bigger pools so that we can answer these questions much faster. One of the most important things in this analysis is that the patients in the control group, if we're talking about aneurysms in control patients, have to be very, very carefully selected. We heard this morning from Frank that when they rescreen those patients who had a normal aorta 5 years later, 2% of them now had aneurysms. So if I take a 67-year-old patient who smokes and I screen him and he doesn't have an aneurysm, so I take blood from that patient and I put him in the control group, but 5 years later he has an aneurysm, now I've really screwed up my study because I'm going to need a lot more patients to find a difference because I'm putting aneurysm patients in the control group. And so those are the kind of things that I think we could reach consensus on in terms of developing protocols so that we're talking about the same things and we could actually share samples and compare data in a way that would be much more meaningful. So just in summary, the practical medical management of aortic aneurysms right now is blood pressure control. Statins, I think for most of the patients have an indication for statins. I was at a cardiology meeting. I asked them, how many of you would treat aneurysm patients with a statin just because of the aneurysm? Very few said they would. So I don't know if we have enough data to say that we should be doing that. But I think if you look closely, most of these patients have other indications for statins. Certainly smoking cessation is something we should encourage. What are viable therapies that we might test in randomized controlled trials? I think statins is probably not one we can test. We can't test aspirin therapy for obvious reasons. But I think the macrolide tetracycline, again, exercise is something they're working on here. J and K inhibition maybe down the road, but probably the tetracycline is going to be the most viable. So thank you very much.
That was a very nice summary. Tim was quite modest, but he just published a paper in Circulation kind of summarizing medical management of aortic aneurysm disease. So your timing was impeccable, Tim. We got about just a few minutes yet before the shuttle leaves, so we have some time for questions, and Julie will give us our instructions about how to get to the bus and everything. So, Mike.
Hi, Tim, that was a great talk. I wanted to make one comment. It was disappointing to hear that, talking with cardiologists, that they wouldn't treat for AAA alone. I mean, I view that as standard practice should be exactly what you've written there. Someone with a AAA needs an LDL below 100 and needs a statin to get there. So I'm not sure why that's still a debate or an issue. But kind of as part of that, I was curious with your trial, you showed some prior data where there was short-term treatment. What's the duration of treatment that you're contemplating for the doxycycline trial, and what are you going to do about statins in the patients enrolled in the trial?
Two good
Can
questions.
you talk in the mic, Tim?
Yeah, good questions. The question was what would be the duration of treatment? And so in this one trial that I showed you, this small trial, which wasn't done by us, but they did 3 months of treatment. Our goal, our plan is just continuous treatment. And so there's a placebo group and there's a doxycycline group, and it's 100 milligrams twice a day, and those patients would be treated throughout the duration of the trial. In terms of what we would do about statins, we would like to do some sort of stratification that would maybe make it possible to look at statins and see if they're individually having an effect. The effect is really important because if statins work independently of doxycycline, they would be synergistic with doxycycline. If statins have an overlapping mechanism with doxycycline, we'll lose that effect in the trial. So it's kind of an important question. But right now, we don't feel like we'll have enough patients in this trial as it's currently designed to stratify. We're going to stratify in a few other things. So we're really just going to have to look at that data retrospectively, and that's the best analysis we're going to have of it. But it is a confounding factor.
So I think as Mike's alluding to, we had considered putting a statin arm in the SCORE project with a crossover design, and power calculations suggested we would just need an unrealistically large number of patients to have any statistical validity. And then the other problem is everybody's on statins already, so you can try 2 different doses of statins or something like that. And you could argue the relative difference between 40 milligrams of simvastatin a day versus 80 is not going to be sensitive enough to determine that, so we kind of abandoned that idea.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.